welcome to all of you from Vienna, home office, as you see, as usual now today. Well, why are we talking about care workers, and why do we need to talk about care work and mobile care workers also in hopefully soon coming non-COVID times? Well, the main reason for this is, of course, the aging of the European population. This is a phenomenon which is characterizing European demography since the 1970s and 1980s. What you see here is a map showing the projected old age dependency ratio in Europe based on Eurostat data from 2014. And as you see, this is a very interesting map showing very different developments. But coming back to population aging, there are two main drivers for population aging which reinforce each other. On the one hand, we see since the last 30 years a growth of longevity due to improved living conditions, improved hygiene standards, and of course the development of medicine. Estimates are that on average, we gain some 2 to 3 months each year for our lifespan. On the other hand, since the 1980s, we also see a general trend in Europe towards a declining average fertility rate. The average number of children in the family, of the average number of children born to women is declining continuously. And all these trends can be seen in all European countries, albeit in different intensity, of course, and they reinforce each other. From a demographic point of view, the old age dependency ratio, the number of persons who are aged 65 plus, as percentage of the number of those aged 15 to 64, is the main measurement for population aging. This is, of course, based on the idea that people from age 65 plus won't be active in the labor market anymore, and those active in the labor market will be mainly in the age range between 15 and 64. Of course, this will change in future. We will see later retirement ages. But nevertheless, even if we calculate with age range 70 plus and a working age 15 to 70, things don't change that much. Because the old age dependency ratio will, as the map show, be between 40% and 50% in France, Benelux countries, Finland, Sweden, and the UK in 2060, between 50 and 60% in Austria, Czech Republic, Estonia, Germany, Greece, Hungary, Italy, and others, and between 60 and 70% in Bulgaria, Latvia, Poland, Romania, and Slovakia in the 2060s. This calculation is based on demographic development and based on migration as we have seen it in the last 15 years. Well, this will be a change. I don't have the figures on the actual rates and on the slides, but I will tell you them. As of 2017, the average old age dependency ratio in the European Union average was approximately 30%. Highest figures in Italy with some 35%, Greece and Finland around 33%, and lower figures around 21% in Luxembourg, Ireland, Slovakia, and Cyprus. And over the past 2 decades, this old age dependency ratio has increased in all member states. And the largest increases we have seen in Finland from 21.7% to 33%, Malta, Slovenia, Lithuania, Portugal, Greece, Germany, and Latvia. So you see the changes are not really linked to the geographic position of the countries or the question if this is an old or new member states, these changes are happening everywhere. And numerous studies have shown that this is a secular trend which cannot be stopped by policy interventions. Although we all know that both in France and Sweden, reproduction rates are consistently higher than in other European countries, also there the rates are declining, albeit at a slower pace. This means that compared to 2010, 2020s, there will be fewer children available to care for the elderly parents. And these fewer children who are the parents of the 2040s and 2050s will again have fewer children. So the question of who will be caring for the aging population of Europe is a highly relevant one. Well, we are talking about long-term care. The growth of longevity is linked, of course, to a growth of elderly people who are in need of some time of care. But here we have to be very careful with the usage of our terms. For many people, the understanding of care means medical care in a hospital or care for the elderly in a nursing home. And this is linked to an understanding of care which was prominent in the last 20, 30 years. 30 years, 40 years ago, the guiding paradigm of care was that people either stayed at home and would be cared for by their children or relatives, mainly the daughters, mainly the spouses. And on the other hand, would be moved to a home for the elderly, to a nursing home, if this wasn't possible anymore. This philosophy has changed a lot in the last 20, 30 years. Now there's a general focus to allow keeping elderly people staying at home, living at home independently in their own apartment as long as possible. And in this context, the idea of long-term care developed, and it's not the type of care needed for people staying in a nursing home needing 24 hours medical care, but it's support for living independently at home, some support to continue to live in the known community and their own apartment. So, for example, the US National Institute of Aging defines long-term care, as you can read here. It involves a variety of services designed to meet a person's health or personal care needs during a short or a long period of time. And these services help people live as independently and safely as possible when they can no longer perform everyday activities on their own. So these long-term care aspects have been new in the 1970s and 1980s, but are now guiding principles in the area of care. They have even been mentioned as a social right in the European Pillar of Social Rights, which has been suggested by the European Commission in 2017. This European Pillar of Social Rights is made up of 20 principles, which should cover all the social rights of people living in Europe. And Principle 18 is dealing with long-term care. And it states as a social right, the right to affordable long-term care services of good quality, in particularly home care and community-based services. So it is important to see that the European Commission doesn't only implement a right to long-term care, but also focuses on care delivered at home or by community-based services, allowing people to stay in the community and the familiar housing situation as long as possible. How is this focus on long-term care reflected in practice? In 2019, the OECD, the Organization of Economic Cooperation and Development, published a study based on 2017 data analyzing long-term care spending and long-term care policies in the OECD countries. And as you see, the average of the OECD is a spending of some 1.7% of the GDP for long-term care. A large group of so-called older European Union countries spend between 1.4 and 2%. And it's particularly the Scandinavian countries, the Netherlands, Norway, and Sweden, which have the highest share, around 3.2 to 3.7%. Most progress countries which are members of the OECD spend below 1%, and Poland, Estonia, Latvia, and Hungary are on the lowest slide with 0.2 to 0.4% of the GDP. These huge differences, of course, reflect the development of care systems in these European countries. Traditionally, long-term care has been provided either by mainly female family members or in nursing homes. As the graph shows, the relevance of social care, which does not focus on the medical aspects, but on the support to live an independent life, is already high in most countries, spending more or around the average, but not that high in many other countries which are below the average spending. So this is a clear hint that there's a change process going on at the moment. So there's a hint that at the moment we see that the care for elderly in the family is declining, and there is a need for other types of care. And this is also seen in the next slide, which will show you the relation between inpatient long-term care spending and home-based long-term care spending from the same study. Here you see that most, but not all Prague process countries still use most of the spending for inpatient care, for care in care homes, in nursing homes for the elderly, while OECD countries, which are old European Union countries, most often will be found among spending more than average on home-based long-term care. That is not the case for all countries. So you see, for example, Poland spending a high percentage of for home-based care. But if you see that Poland is spending 0.2 to 0.4% of the GDP, this is also influenced by the general relevance of care spending. So you have to be careful when looking at these slides. And these differences are, of course, due to the fact that the landscape of care which we find in Europe has developed according to the welfare state configurations, which are very different in European countries. And so now there are a variety of arrangements to be found for the provision of care, which we will discuss in the next slide. I go to the Russian version here. Let us have a closer look at the main long-term care settings we do find in the different European countries. One of the main issues for differentiation is the place of care. Care may be provided at the family home, at the apartment or in the house where the person is living, or it might be provided in a situation where the patient has to move to another housing situation. For those staying at home, we do find three different settings. The vast majority of those living at home is still cared for by family members. In most cases, female family members. The system is very typical for so-called conservative welfare states, which have a familialistic outlook to care, but also very, very often to be found in Eastern European countries. Here, financial subsidies provided by the state quite often are an incentive to care for the elderly at home in a way that the client will get a certain amount of money to be spent freely, which can then be spent either for buying care at the market or for gratifying family members for doing the care work. Of course, in this case, medical staff like nurses, doctors may come from time to time to support the elderly persons, but this will be a normal service delivery through visits at the family. We do find in this situation a second setting, which is very typical for German-speaking countries. Here, large humanitarian organizations, like for example, the Red Cross or the Caritas or other organizations affiliated to a religious community, will be paid for the state to provide mobile care services. In this case, a caregiver will visit a number of clients each day and support each client for a certain time, half an hour, 2 hours, in areas like personal hygiene, cooking or cleaning of the flat. These mobile care services are in a different way, but comparably organized by municipal or communal service providers in many Benelux countries. Here, it's not so much the Caritas or the humanitarian organizations, but the communities and the municipalities which provide this type of mobile care. Also, in this case, the elderly client is supported in leading an independent life and can stay at his or her home. Caregivers, in this case, hold regular employment contracts either with this humanitarian organization or with the municipality. The share of migrant care workers here is differing widely, can be very high to rather low depending on the local situation. But these migrants are settled migrants who live in the country and work their shifts as employees in these types of organizations. Very important, as they work their shifts, they have a private apartment where to live. In Austria, Switzerland, parts of Germany, but also in Italy and Spain, we see a specific third model, the so-called live-in 24/7 hours care regime. In this case, a caregiver lives in the apartment or house of the client and supports him or her in the daily routines. Also, in this case, some medical support may be provided by visiting nurses or doctors. But this medical support is not provided by the caregiver, him or herself. Caregivers usually are not employed, but working either as in the form of dependent self-employment, which is an arrangement to be found, for example, in Austria, or as seconded workers making use of the secondment directive of the European Union, which can be found mainly in Germany, or are working irregularly, which is often the case in Italy and Spain. Matching between clients and caregivers is done by matching agencies, which demand regular fees from clients and caregivers. This type of care work is highly dependent on a specific type of mobility, in particularly long-term commuting, where this long-term commuting may be for 2 weeks up to several months, and where the caregiver doesn't have an own apartment to live, but spends all the time in the flat or the house of the client. Within the European Union, this model is based on the freedom of movement regulations, allowing delivery of service and mobility. But we also see a growing number of third country nationals, particularly from the Ukraine and Moldova, working irregularly in this sector. This type of arrangement is very critically discussed both by organizations of caregivers and trade unions and care experts. But on the other hand, it's a model highly in demand, and it's a model which can be funded by the clients with support of the state. The second type are models linked to a move to different residence. And here we find also very different models. We find, which is only a more modern, more new model, living communities of the elderly, where elderly people live in a shared flat and are supported. We have assisted living facilities where there are several flats and there is a regular support service, or we have residential care facilities. All of these provide some easy access to care services, either through visiting caregivers or through services provided within the facility. Also here, the client moves away from his home and moves into a new housing setting. He or she will have an independent flat to live and services to be used on demand. Also here, staff employed in these settings work on regular contracts. The percentage of settled migrants working in this area is usually rather high. Finally, nursing homes are usually the place where those live who are in high demand of medical care. Here, also medical staff is employed, doctors and nurses, and they are available on a daily basis. Also here, we see a usually high number of settled migrants as a main resource of staffing. I have now explained these different settings in order to clarify the distinction between mobile care and mobility in care. Mobile care means care services which are visiting a client at home, which are provided by agencies, social support services, or companies. People working there have regular employment contracts and work their shifts. And this is a labor market both for natives and settled migrants. The reason being that usually the clients would like to have the services delivered in their mother tongue, so there are language requirements attached to it. This mobile caregivers, mobility in care, is usually provided by carers which commute between the country of origin and place of service. It's a model of live-in care, meaning that the caregivers do not have their own apartment to live, but live with the client in his or her housing. And it's usually done in the dependent and self-employment or with irregular employment. So usually you do not find regular employment contracts in this type of setting. In order to allow a mobility in care regime, a mobility regime allowing some kind of freedom of movement must exist. In the European Union is the freedom of movement regime. Or in Poland, we find a circular migration regime between Poland and the Ukraine, where Ukraine care workers can more or less move freely. If no such regimes exist, it is very likely that the demand for this type of service will be fulfilled by irregular migration and irregular employment, which we see quite often in southern countries like Italy or Spain. Now, let me come to a kind of overview, which is has been done by an expert of the European Center of Social Welfare Policy and Research, giving a kind of country-wise overview on the different care systems. And we see that in Europe, we have 4 different types of care mixes. A standard care mix, which means that you have a lot of formalized care elements. A universal model where formal care is very, very dominant. A family-based model, which is very often to be found in southern countries, but also in Ireland. And in Central and Eastern Europe, we have a specific model where there is still a low or medium demand for long-term care and high informal care provisions. The role of migrant workers differs in these types, in these systems. In the standard care mix, which is Germany, Austria, France, and UK, we have a very high demand of migrant workers. In the Nordic countries, the demand for migrant workers is not that high. There is a medium to low demand, and migrant workers usually work only in nursing homes or medical care facilities. The family-based model, Spain, Italy, Portugal, Ireland, there's a very high demand for migrant workers. And in the Central and Eastern European countries, the demand is still low, although we see changes, for example, a growing number of Ukrainian caregivers in Poland. These different types of care services are linked to different levels of qualification in the care system. In the formal health system, it is very clear we have a high number of trained staff working, trained migrants, trained doctors, trained nurses, which of course links migration to the issue of brain drain. There is also support staff, cleaning and cooking, which are lower qualified people. In the formal long-term care system, where service is provided by organizations or by the municipalities, we do find some nurses and nursing aides as workers, but a lot of home helpers who deliver support in cleaning and cooking, which will be lower qualified. And in the live-in care system for private households, we find informal to formal ways of organization. We find both trained and untrained staff, and we find different types of commuting, short, midterm, or constant. But here the main workforce, the main qualification level is more of a lower kind. So in all of Europe, we see a very, very diverse picture. And we also see that very diverse types of migrants are looked for and are working in this field. Now, coming to the last slide, what migration flows can be seen in long-term care? Well, this short overview clearly shows that there is one element which is a clear pattern. Eastern European countries are the source countries, and Western European countries are usually the target countries for migration in care. Here you see the arrows from the different countries, and you will also see plus, and the more plus, the more important these flows are, of course. But again, here we see very different pictures. Large target areas like Italy, Germany, or the UK have very different sources for this type of migrant caregivers. Germany receives care workers mainly from Poland, the Czech Republic, Slovakia, and Hungary. The UK care workers are coming both from Poland and from Asia, so there's also intercontinental migration involved. In France, the majority of care workers working there are coming from Northern Africa. Spain is serviced by care workers from South Americas. For the South Americas, this is the main important, the main source, simply because many South American countries have visa-free travel arrangements with Spain, but also from Asia, Africa, and to a certain extent, also from Romania. Austria, for example, is mainly serviced by care workers from Slovakia, Hungary, and Romania. And Slovakia and Romania are also those countries which are highly relevant for Italy, but for Italy, it's also the Ukraine or Moldova. So these different systems have led to very different flows of migration, whereby those flows which are done within the European Union are usually handled by freedom of service, freedom of movement conditions, which means that there is regular and legal migration. There might be irregular work involved, but it's still a system where the mobility regime allows these flows. The flows from Ukraine, Moldova are very often also linked to irregular migration, and Africa and Asia depends on the bilateral agreements the countries have with the source countries. I will stop here now and hand over to Madalina, to my colleague Madalina, who will explain a very typical model for this type of care workers, the 24/7 hours care worker system in Austria and its linkages to the whole debate on care.
I will continue. So in this second part of our presentation, I would like to provide you with an example. First, I will briefly describe the long-term care regime and the various types of long-term care that are being provided to older people in Austria. Then I would like to focus on 24-hour care work, which has been provided for decades by migrant and mobile care workers. And I will then move to discuss some of the impacts of the COVID-19 crisis and measures implemented to address these impacts, as well as some policy implications. So this information comes from both existing relevant literature, but also from our own research conducted with care workers and organizations representing the rights of care workers in Austria. Together with fellow researchers from the Johannes Kepler University in Linz and from the Slovak Academy of Sciences, we contributed with an article on the impacts of COVID-19 on 24-hour care in Austria, which was submitted to the Global Social Policy. In connection to what Bernhard mentioned earlier, the policy interest in long-term care systems increased in recent decades due to, among others, demographic changes. So the Austrian case is a very interesting one for several reasons. So first, the share of people aged 65 or over in Austria is around 19%, so close to the share of 65 or older in Europe, where the share is about 20%. Second, in 2020, Austria implemented a series of measures to address the impacts of the COVID-19 crisis in order to make sure that older people in need of care continue to be cared for. And these measures included support to care workers coming to Austria from neighboring countries. But to speak of Austrian long-term care regime, one has to take into account that Austria is a strong welfare state, with the long-term care being a part of it. So let us mention a few important points from a historical perspective. So in 1993, Austria introduced a new care provision scheme, which included a tax-funded, universal, non-means tested benefit, in German called Pflegegeld. According to literature, this benefit builds on the availability of unpaid or cheap care provided within the family. This benefit is paid by the federal government, and payments are granted to the person in need of care in 7 categories or levels, depending on the amount of care needed. So this care benefit, also called nursing care allowance, is aimed at enabling persons in need of nursing and care to remain in their homes as long as possible, while retaining the control over managing their lives. So the second provision regarded the Austrian federal provinces, the Länder, who committed themselves to the nationwide extension of outpatient, semi-residential, and residential care facilities for long-term care. So the care services available were expanded, with the federal provinces being responsible for the quality of these services. So, however, research on the usage of care services introduced showed that although professional home care services have expanded, their use was restricted by the lack of availability and flexibility due to underfunding of the providers and by the high costs for the users. Another mention which is worth measure which is worth mentioning is the introduction in 2014 in the Austrian long-term care regime of two variants of leave, care leave and part-time care leave for standard duration of 3 months. So this was the first policy measure to be focused on carers rather than on the persons in need of care. And some say that it indicated a new approach in the Austrian long-term care regime, so addressing the need of family members who are providing care within the family. Now, against this background, and considering that majority of care need is being met by carers within families, the Austrian long-term care regime conforms to what was called a familialism model, which actively supports and in fact enforces the family's involvement in providing care. So although a high proportion of care needs continues to be met within the family, mostly provided by female family members of the persons in need of care, there are three main elements or types of care which do not necessarily involve family members, which I would like to mention. So as Bernhard mentioned earlier, inpatient care is organized in nursing homes and homes for the elderly operated by different owners, such as churches, welfare associations, humanitarian organizations, municipal or provincial government, as well as private companies. Mobile care is provided by private companies, welfare associations, NGOs, and municipalities. In this case, caregivers employed by one of the organizations mentioned are regularly visiting the client for 1 or more hours a day and provide care in the household of the client. The third type of care is the provision of 24-hour care. The 24-hour care system is a combination of traditional family-oriented care and the universal nursing care allowance. Now, I would like to add a few words on the funding on the above-mentioned types of care, since this is relevant for the care work mobility system, which I will mention in a minute. So inpatient care organized in nursing homes and homes for the elderly is funded by the Austrian federal provinces, and patients have to contribute to the costs of inpatient care with approximately 75% of their income. So in addition, the nursing home will receive the care benefit, so the Pflegegeld, applicable according to the care level of the patient. In case of mobile care, the client pays the respective fees to the organization providing care. In this case, depending on the care level, the client receives the care benefit directly. The provision of 24-hour care in private homes is funded by the federal care benefit, so this Pflegegeld, and additional benefits. So there are no restrictions on how the care benefit is spent. The form of spending is entirely up to the recipient, whether on home adaptation, buying professional care from various organizations, paying family members, or hiring private care workers. And there is no requirement for employing trained caregivers. But in order to foster the employment of qualified caregivers, a further 24-hour care subsidy can be granted to persons that are classified at least at care level 3 from those 7 levels and are in need of 24-hour care trained caregivers. So this additional benefit for hiring trained carers can reach the amount of 550 euros per month or even 1,100 euros per month, depending on the number of carers employed and the type of the contract. But in principle, the care recipient has to show that there is a need for more than one care worker, and the care recipient has also an income under a certain threshold. So this was some background on the types of care provided in the Austrian long-term care system. Now, let's turn to the 24-hour care provision, the one most affected by the COVID-19 crisis. As of the early 1990s, 24-hour care has been provided in Austria through irregular employment, mainly by female workers coming from neighboring countries. The debate on the situation of 24-hour care gained momentum in 2006 when it became known that the mother-in-law of, at the time, the federal chancellor, had been cared by irregularly employed caregivers, while he, the chancellor, was publicly denying the need for a regulation of 24-hour care. So following this debate, in 2007, a new legislation was passed defining two legal options for 24-hour care: standard employment and self-employment. And self-employment covers about 99% of all 24-hour care work in Austria. Under the self-employment model, care arrangements for 24-hour care on average cost between 2,000 and 4,000 euros per month. And from this, about half is covered by the federal care benefit and subsidies, while the rest is paid by the family of the person in need of care. The 24-hour care model is preferred since, with the care benefit contributions, it represents a more flexible model and is affordable for middle and upper income families. Plus, the person in need of care can continue to live and be cared for in their own home. This type of care provision is a growing sector and is dominated by care workers from Central and Eastern Europe, mainly Romania and Slovakia, but also from Bulgaria, Hungary, or Poland. Typical for 24-hour care in private homes is the live-in model and the rotational system of sharing jobs. So for instance, a care worker from Slovakia commutes on a bi-weekly basis between their home in Slovakia and the private household of an elderly she cares for in Austria. She spends 2 weeks working in Austria and then 2 weeks in Slovakia, and so on and so forth. A care worker from Romania usually commutes on a 4-week basis between their home in Romania and the private household in Austria. But to find such work, care workers turn to a brokering agency to find them such a client that is in need of care services. To legally engage in this type of work in Austria as self-employed, one has to go to the economic chamber and get a self-employed license for offering the service of care, thus opening a one-person business. So it is important to mention that through self-employment, the relationship between the caregiver and the person cared for becomes a service provision relationship, so a business-like relation. And this does not fall under the Austrian labor law. Also important to note is that the agencies that mediate the contact between workers and persons in need of care in Austria are often also self-employed, holding an active self-employed license from the same economic chamber. So here are two narratives. In one, agencies are supporting care workers find clients against a fee, arrange for their documents, help them obtain the license, fill in the papers necessary for insurances, negotiate their contracts with clients, etc. But another story is that agencies, although they charge these fees twice, sometimes from the care worker and also from the client, do not cover their part of the bargain. So do not pay insurances, do not negotiate working conditions. So when a conflict arises between a self-employed care worker and an agency, the same economic chamber represents their interests. So whose interests would come first? There are now at least 2 care workers' interest groups that are active in the media and in conversation with the Austrian government in the context of the current Austrian care reform. So now, to sum up, since its legalization in 2007, 24-hour care or live-in care model has become an important pillar of the Austrian long-term care system, and its importance is expected to increase. In 2010, about 25,000 care workers had an active license from the economic chamber. Their number grew to over 62,000 by 2017, and similar numbers were reported at the end of 2019. So the most important countries of origin are Romania, 47% of licenses are held by Romanians, and Slovakia with 33% of the licenses. In early 2020, almost 33,000 households in Austria relied on a self-employed care worker. So far, I briefly described the Austrian long-term care regime and the types of care provided, as well as the 24-hour care model, which involves the mobility of care workers from Eastern European countries. Now, I would like to address some of the impacts of the COVID-19 crisis, and to a certain extent, this this crisis continues and the impacts continue on the provision of 24-hour care and care workers. In the first months of the pandemic, European countries, including Austria, imposed travel restrictions, which severely affected care mobility. So as a result of measures to contain the pandemic, many care workers, both those who were supposed to commute from Austria to Romania or to Slovakia at the end of their rotas, and those who were supposed to commute to Austria to replace them, were unable to travel internationally. So some care workers decided not to travel, either because of the borders that were closed, the quarantine and testing requirements. There was also fear of contagion. There was fear that they would lose their jobs. They had different situations at home, or because the minibuses that usually are organized by the agencies were not operating. In the first months of travel restriction, there was a lot of confusion among care workers with regard to the travel rules. So while Romanian care workers who were already in Austria and wanted to travel back to their families reported little to no support from Romanian institutions and from placement agencies, Slovak care workers were reportedly receiving support in terms of information from the agencies. Many care workers had to extend their rotas. So instead of working 4 weeks, they ended up staying in Austria several months, which meant that they reached a point of exhaustion with virtual no breaks, having to work also on Sundays. Usually on Sundays, family members of the people in need of care are coming to visit. So so care workers have a break. But in the beginning of the pandemic, family members were advised not to do that in order to prevent the spread of the virus. So care workers ended up working or being on call also on Sundays. Previous research on transnational care work showed that women working in care abroad remain involved in caring for their families at home and providing for their needs of care. So extended rotas meant that many families in sending countries remain without this care. In the first months of restrictions, extended rotas of care workers already in Austria also meant that care workers who were supposed to replace them were no longer able to do so. Therefore, their families in countries of origin suffered loss of income, at least in the first months of restrictions. As a first reaction, agencies and households asked care workers already in Austria to extend their stays, even as opportunities for them to leave came up, particularly for those from neighboring Slovakia. So as a second strategy, families of care recipients and agencies demanded exceptions from the travel restrictions to enable carers to cross the closed borders. So in Austria, the federal government initiated negotiations for free passage for care workers, and some federal provinces collaborated with their economic chambers and the agencies to organize charter flights from Romania or Bulgaria. In addition, in May 2020, 6 special trains from Romania brought in care workers that allowed then Romanian care workers already in Austria to travel back to Romania. So these measures were enabled by the early introduction of mandatory COVID-19 tests and quarantine for all commuters, including care workers. However, as an incentive, when traveling by train, care workers no longer had to remain in the 2-week quarantine, but were tested on arrival and had to stay in a hotel for 1 night until the test results were available. But there was uncertainty and confusion about the cost of having to stay in quarantine. So the cost of the hotel in case of a positive test came up, because it was not clear who had to pay for this hotel. One stakeholder that we interviewed said that it was apparently a matter of negotiation between individual care workers and their respective agencies. But the 2-week bill may correspond to the monthly income of a live-in care worker, so is therefore not affordable to them. In addition, Austria introduced a one-time tax-free bonus of 500 euros for rota extensions of at least 4 weeks. However, in most federal provinces, official information was available in German only, so the application and payment procedures varied from one province to another. In some provinces, the care recipients had to apply for this bonus and pass it on to the care worker. Interviews with care workers associations revealed that not all care workers received this bonus, or they did not receive it fully. Another measure introduced was the hardship fund to mitigate negative economic effects of the pandemic on small businesses, including the self-employed. So personal carers were eligible for monthly support up to 2,500 euros for a period of initially 3, later 6 months. However, in practice, many live-in carers did not have access to the fund because they lacked the necessary documents, such as an Austrian bank account or a tax number. In addition, it was available in German only, and some struggled to fill the detailed application form. Another measure introduced addressed the household's access to additional public allowance for 24-hour care. Interestingly, this was simplified. So households or care recipients didn't have to do anything. So for the duration of the pandemic, it was no longer required for them to have 2 care workers that alternate in the same month in order to receive this 550 euros bonus. So to sum up, Austria implemented a series of measures to enable care workers to cross borders, to enable them to stay longer shifts in Austria, and to support those who do not have an income in times of crisis. However, the way these measures were implemented, particularly with regard to the fact that most information was provided in German only and that documentation needed to access these bonuses was not adapted to the realities of mobile care workers, show that from the Austrian perspective, the financial interests of live-in care recipients are more important than those of workers providing care. So in essence, the system itself, it's more important than the mobile care workers, although the mobile care workers are essential to this system. So what does this mean in terms of policy implications? First, the pandemic underlined that migrant care workers are essential for health and long-term care systems. However, it remains to be seen whether the 24-hour care model and the care workers' position and the bargaining power, particularly in Austria, will evolve or will remain unchanged. In case the economic situation in the countries of origin worsens, it could increase the financial pressure on care workers and also their dependence on providing 24-hour care in Austria. But since both sending and receiving countries face demographic changes, a critical examination of the system's sustainability becomes vital, including concerning care mobility and its commuting workers. Another important point is that care work is dominated by female migrant workers. So during the pandemic so far, in addition to health outcomes, women have also been found to report greater social isolation, loneliness, and financial stress. With the number of older people with long-term care needs expected to increase in Europe, the role of women both in informal care, but also within their own families, but also as transnational care workers will continue to be more and more relevant. That being said, I will close by raising some points for reflection, points that require further research and consideration, such as, are there comparable developments in other PROSEC countries? Are there other comparable developments, but also what are the effects of the COVID-19 crisis on workers sending countries? Or what care arrangements should the PROSEC countries envisage for the future?
We do not see a European platform linking the countries which are mainly countries of origin of care workers and the countries where there is a demand for this type of care. So what we see are bilateral talks, bilateral agreements maybe, then developments which are more or less shaped by, as Madalena has shown, by agencies, by care agencies. So there is no kind of dialogue platform involving all actors. This could be something where a process like the Prague process or an international migration dialogue process could suggest meetings of the relevant authorities of both countries and discussions to come to a more coordinated approach.
In principle, what we've seen from the research we've conducted in European countries, important would be to have an approach centered on the worker and the worker's rights. So that is an issue because particularly live-in care shows that workers have very difficult working conditions, and there is a lack of understanding of that and the lack of measures to support them. Because in a private household, you do not really have a third actor who comes and checks how actually the work is being conducted. So whether the workers' rights are respected, or also the quality of the care. So there is a need for regulation in this area. So as Ben had mentioned, basically in this platform of discussion, this can be one point to mention, which is a very important point. And care workers and care workers associations have mentioned this basically every time we talk to them.
Maybe let me just come to the European element. There are NGOs, particularly Caritas Europe is trying to have an European, working for European standards. And there are NGOs which are demanding the debate at the European Union level with regard to the mentioned pillar of social rights. But this debate is very much in the beginning, I would say. And there are, at the moment, the debate focuses on the kind also of understanding what is seen as the necessary training levels, what is the type of training, the diplomas, and the kind of comparability of certificates. So, and there is a need for that. What we found in another study also, there's also an important need to regulate another element which you don't think that it's linked to care, but we have really problems been reported regarding the transport facilities. So the transport of the caregivers is usually done with minibus services, and minibus services are not regulated in Europe. So everyone holding a driving license, I with my normal driving license could open easily a minibus service offering the services. And other than drivers of buses and other public transport where there are strict regulations on resting time, on the standard of the car, etc., there is no regulation at all. And there have been very heavy accidents already. So there's also a need to think about regulating minibus services, because the transport services provided are really dangerous, and also in COVID times. Minibuses are not the best way to drive, to travel in COVID times.
Really depends on the systems of countries. So of course, for instance, to give an example, you have Romanians working in Austria for care, but at the same time, because of the mobility system, the same care worker remains responsible for the care in their own homes, right? So Romanians would not then necessarily employ somebody to care for the elderly in their families. There is a situation in which they employ somebody from the same village or from the same community, but it's not that widespread as in Austria to have a migrant or mobility care workers from other countries. So it really depends. So in principle, if you think about it, yes, there is this is a reality, but it really depends on the system of the country and whether the long-term care system is based on the family, is centered around the family, or whether there is also support offered to families, or there's also special facilities, basically, and clients have access to those. So I think it really depends. You cannot really generalize and say that this will happen. Of course, one stakeholder I interviewed in Austria was telling me that do not worry. Now there are Slovak care workers and Romanian care workers, but then Bulgarians will come more. So there is still a pool of mobile care workers from which we will have enough workers in the future. So there's no need basically to change the working condition at this point. But yeah, the debate continues. To the question you just raised, as I mentioned in the very beginning of the presentation, I contributed to an article together with fellow researchers from the Slovak Academy of Sciences and Johannes Kepler University in Linz, and we hope that that article will be published once it goes through peer review. But we also, hope to publish something related to that. From ICMPD side, from policy side, but yeah, perhaps Bernhard, you have more details on that, on when that will be ready.
We have a policy paper in the making on trans in this care regimes. This should be ready in 2 months, something like this, and of course can be then shared. This touches on a very relevant point which I made. The interesting thing is that when we look on care issues from the perspective of a migration researcher, we have to see what type of regimes are behind it. And we have the interesting situation that, as Madalina has shown, this model of self-employment, of dependent self-employment in Austria, where people have to register with the economic chamber, is only possible in the framework of freedom of movement in the European Union. As union citizen, you are, of course, entitled to provide services. This is basic. This is the fundamental freedom of the European Union. So, as Romanian citizen, as Bulgarian citizen, you can easily go to the chamber, register yourself, and do this work. You can't do that as an Ukrainian citizen. As an Ukrainian citizen, you can't provide self-employed work because you need to follow the migration requirements in Austria. And the migration requirements are shaped by a point system where, of course, you can come as a self-employed person, but only if you invest into or have the idea to have a very innovative company set up, something like that. All other work, labor migration is regulated by a point system, where you have to provide that you are a member of working in a profession in demand or have certain qualifications, etc., etc. Care workers, care providers usually don't fall under that. So what is happening now, what we see in the beginning, but it's very, very limited in Austria, is that there is again some irregular migration, making use of visa-free travel between Ukraine and European Union. And the same goes, for example, if we go to Spain, where we have Latin American immigration, South American immigration based on freedom of movement arrangements. Not freedom of movement, sorry, visa-free travel arrangements. So the interesting point now in Austria is that, say, an irregularly employed Ukrainian national providing care services, if this becomes known to the authorities, there will be, of course, he will have to leave the country. He will get an order to leave, but he can claim employment salaries as an employed person because he can only be employed. So from the labor law perspective, the labor law wouldn't allow a third country national to be employed as self-employed person. This is only possible within the European Union framework. So all these care arrangements with mobile care have to be also seen from the migration perspective. So to do it and to have it in a regulated way, you need a framework for mobility, which in the European Union exists. There is the similar framework or similar. There is a framework for temporary migration between Poland and the Ukraine, which allows this type. And the other types are mainly irregular because no framework exists. I don't know if Madalina knows, I haven't heard about this yet. This is an issue which is highly debated in Germany now. Because in Germany, there is no regulation like in Austria for dependent self-employment. So people can be regularly employed, or there are mainly posted workers from Poland, from Polish agencies, who are then posted to Germany. And there's now a debate going on there that the German authorities compete or do not accept posting from Ukrainian workers from Poland to Germany who have not been working for a certain time period, half a year, I think, in Poland before, but simply have started to work in Poland for the agency and then have been posted. There are a lot of cases in Germany now pending because the German authorities say this is a misuse of the posted workers directive. In Austria, I didn't hear about it. Maybe Madalena has heard it, because in Austria, the vast majority of these arrangements is done within this European Union framework and this dependent self-employment. But maybe Madalena, you can add.
Yeah, in Austria, most care workers are EU citizens. So yeah, I'm not aware of this development, particularly in Austria.
What has been mentioned by some articles in the newspapers, particularly in the Burgenland, that there are Ukrainian care workers, but they are working irregularly. So they're coming with this visa-free arrangement and then working irregularly. But this is more anecdotal evidence than real evidence.